Today is a great opportunity for me to communicate all over Chautauqua County on a very, very important topic. I've read the letters from families. I've seen the impact in our community. Drug abuse and the problems with opiates and heroin addiction has hit every aspect of our community. From the young to the old, from our students to our working families, on every segment of our society, we have got to get a handle on this problem. When I was elected, I heard about the problem of drugs and problems with prescription opiates in Chautauqua County, and so I decided to have a forum. I wanted to bring people together to discuss this very, very important topic. I wanted to educate, I wanted to learn myself, and I wanted to bring us together, whether we were victims of the problem, whether we were treating the problem, whether it's law enforcement, probation, the court system, everyone has a part to play. So I encourage you to spend some time as you view these video segments and to reflect on what you can do, because we're going to mobilize this entire community to get a handle on drug addiction in Chautauqua County. Thank you for your time and attention to this very important topic. A long time ago, I had a perception that those on drugs or drug abusers, it was just their choice, that this wasn't really a disease. But since then, I've learned a lot. In this next segment, you're going to find out about the medical piece, the fact that drug addiction is a disease. And you're going to hear from Dr. Withers. He's a Chautauqua County native. He attended undergraduate school at SUNY Binghamton, is a medical school at SUNY Upstate in Syracuse, and completed surgical internship at Indiana University. Dr. Withers practiced emergency medicine before he became involved and an expert in addiction medicine. Listen to this important segment.
I'm Pat Brinkman, Director of Mental Hygiene for Chautauqua County, and it is my pleasure to welcome you to Chautauqua County's Community Drug Forum. We are here today to focus on addiction, a chronic disease that affects more than 65% of our families. Addiction is a disease, not a moral failing or a mental weakness. It's an equal opportunity disease striking individuals across all socioeconomic groups, races, and genders. As you look around the room, two of every three people you see will be living a life that has been impacted and changed by their own or a loved one's addiction. Addiction changes not only individuals and families, but communities as well. So today we have come together as a community to focus our minds, our hearts, and our energy on this problem, in the hope that through collaboration and strategic action steps, we can and will make a difference. The carefully selected content crafted by our energetic and enthusiastic planning group and the amazing number of community participants in this audience gives us a reason for optimism. Today is about increasing awareness of the problem, educating ourselves so that we can speak a common language, and about the sharing of ideas and the opportunities for interventions going forward.
Another moderator that's going to help me with this forum, who has brought this in a personal way to my attention, along with many other people who have brought this in a personal way to my attention. So Dale Robbins, Dale, where are you at? I've lost you. Dale is, there he is. I want to give him an opportunity to make a few opening remarks before we go. Dale Robbins.
I've never used one of these, so I apologize for the confusion that may bring to our conversation here. I want to welcome all of you here. I'm thrilled to see the large number of people that are here. today to engage in this learning experience. We all have something to learn from each other. I practice law in Jamestown, New York. I don't do criminal matters, I don't handle them, but I see in my practice, which is more related to real estate, estate planning, and some personal injury work, I see every single day somebody who has a heroin issue in their family, whether it's a child, a spouse, a sibling. In many cases, it's a parent, parents who become addicted to prescription medications and can't deal with them. It translates across all kinds of demographic lines, all kinds of, economics, age, it's everywhere. It's just absolutely penetrated our community. We need to do something about it. And as we go through today, I ask that you listen, you hear, you watch, you see, and you heed, and you follow from what you learn here. Take it with you, and let's all work together to try to resolve these issues. Thank you.
Dr. Withers is a Chautauqua County native. He attended undergraduate school at SUNY Binghamton, medical school at SUNY Upstate in Syracuse, and completed surgical internship at Indiana University. Dr. Withers practiced emergency medicine before beginning his practice in addiction medicine. So please join me in a welcome for Dr. Withers.
No, addiction, if you think about it, it becomes a hole in the soul through which blows the cold north wind of life. Okay? And as these substances, which are ubiquitous in society, impinge on a normal, non-addicted brain, what happens is that person gets high or experiences. Is there a clock around someplace?
Pardon?
Is there a clock around someplace, or? I'll figure out something.
You're doing fine.
Yeah. Yeah, I know it's coming. Anyhow, it's as these substances which are ubiquitous in society, people come across them, and through experimentation and through just wondering what's going to happen, people take them, usually in adolescence or before. And if you think about it also, it's a pediatric disease. And what happens when you first take drugs or drink, there's not a cloud in the sky. Nobody dies. Nobody goes to jail. Nobody gets divorced. You don't end up bankrupt. Nothing tragic happens, usually. Okay? And so what happens is most people will experience something negative happening as a result of substances and essentially grow out of it. And that's about 80% of the population, actually. And so with most of the people in this room, I mean, assuming you're not prone to addiction, you could take heroin, not take heroin, take cocaine, not take cocaine, whatever. And I'm not saying that your behavior would be good with those substances, and this is certainly not an endorsement of drug usage, but you would not become addicted. But then there's that 20%. It's roughly 1 out of 5. And it's interesting because it varies a little bit by drug as to which drug is more addicting. The single most addicting drug, by the way, out of them all, happens to be nicotine. Nicotine is a little bit weird because the consequences come about 20 years later. So when you smoke your first cigarette, normally you do not go to jail. Okay? It's 20 years later, you end up with your heart being shot, and then it gets to be a real problem. But with substances, what happens is what started out as something that became a pleasure or perhaps a want eventually becomes a need. And here's the problem. The problem is there are many things in the environment that are pleasurable. The smell of a pretty flower, your favorite piece of cake, I don't know, whatever it might be. But what happens is if you put that banging on the pleasure center of the brain at a 1, drugs have 10 times the reinforcing power as they bang on the nucleus accumbens in the brain. 10 times, think about it. So the pleasure center of the brain then gets banged on 10 times as hard. And so if you're prone to addiction, what happens is this. I mean, you could have the bite of the toast with your favorite jam on it, and you might say, that's okay. And all of a sudden, heroin or something comes along, and the brain does this. Need to know the name of that one? Just tell me the name. I'm in love. That's what happens. Brain falls in love. And then what happens is these drugs require, there's a concept of tolerance. It requires more and more drug usage over a period of time to achieve the same effect, which is tolerance. Okay? And so what happens also is people try to chase that high. And if you talk to an addict, what the addict will normally say is, the first time was the best. Talk to somebody that used a gram of cocaine sometime. And what they'll say is the first time they got high was the best, or the second. Okay? But not the 50th and not the 100th. And so now there's a great hotbed of research going on in addiction medicine as to why these types of things happen. But at the heart of this, when addiction really gets going, and it will get going, for at least 1 out of 5 people that come across these drugs, it will become a hole in the soul through which blows the cold north wind of life. Now, 50% of this is genetic, and 50% is environmental. So for the same reason that you got your eye color, your facial bone structure, your height, and many, many other characteristics, you got a relative vulnerability and relative protection against addiction. Okay, now, it turns out that this is on a whole slew of genes everywhere. Okay? It's not just one chromosome. So it's not going to be like cystic fibrosis. With cystic fibrosis, it might be on half a dozen genes. And so you might develop some sort of genetic knockout where you give somebody, you know, some soup chopped out of rat DNA, and all of a sudden they don't have cystic fibrosis. This could happen. Okay? But with addiction, because it's on so many genes in so many places with such a variable degree of penetrance, so these genes can be turned on either 1% or 99%. By the time that you get that particular genetic mosaic for that individual, you're talking about a lot of the genome. And if you start putting rat DNA in to try and splice that out, first of all, technology's not there yet. I'm sure it will be for other things like cystic fibrosis. But if you do it with addiction, you're going to do, I think you're probably going to end up with a little bit too much rat in the part of the deal. And I think you're going to end up with like furry ears, a tail, and a profound craving for cheese. I don't believe that this is going to happen as a genetic knockout. Okay, so what you have, and if you think about it, I did emergency medicine for years and years and years and years. And if you think about it, what are the symptoms of pneumonia? They're fever and cough, among other things. What are the symptoms of addiction? Well, stealing money, committing crimes, family disruption, lying. Okay, but they become the symptoms. Now, I understand extremely well that the symptoms have to stop. I know that. That's part of recovery. But there's still symptoms. And what happens, I think, in society is society as a whole, for the last couple of thousand years, has largely rebelled with a few separate episodes in time and a few enlightened people. I mean, you can go back to Greek medical texts and find discussions of addiction. But largely, these things have been considered to be moral failing or something like that, and it's not. What it is it has at least 50% of it is a genetic underpinning. And you have people that are at risk, and then they come across these substances, and then nature takes its course. And 1 out of 10, or half of that 20% that is at tremendous risk, is my population, and I take care of people that are severely addicted that have had tremendous disruption. And it's amazing how much they are able to hold together a life and have it look good on the outside. But the purpose of the drugs is to serve as some measure of insulation against the hole in the soul, so the cold north wind of life does not hurt. And if you're pretty narrow-minded about this, you can say, or very dogmatic, what you can say is just stop. Stop, quit. Okay. I mean, if you think about it, if that was going to work, jail would work great. Just absolutely great. Right? Because what happens in jail? Largely, you have to stop using drugs. You can still use drugs in jail if you're extremely clever and you're able to manipulate extremely well. No one ever likes to think about it, but it can happen. But what happens if you don't treat the addiction and they're released from that particular facility? Sometimes they're high in 20 minutes. I've seen that. Usually about 2 days, unless something has happened, which is the recovery. Well, here's what happens. If you're still walking around with a hole in your soul and you don't feel good, you're going to seek your insulation, and the drugs become the insulation against the cold north wind of life. What is the point of recovery? Recovery is to shrink the hole in the soul. Then the cold north wind of life can blow as hard as it wants to. There's just nothing for it to go through. Okay? What happens then? Someone is happy, joyous, and free. What happens then? You end up with people like the ones that are in this room. They're able to meet their obligations, okay, to live their life and to be fulfilled and not worrying about whether showing up at that particular conference will result in an incarceration because you might run into your probation officer. Okay, whatever. Now, I would also say that early diagnosis is going to be incredibly important. And if you think about it also, it's sort of a pediatric disease. Now, why is that? When does drug experimentation begin, largely? Usually adolescence. How old are you when your brain finally matures? In your 20s, yeah, 26, something like that. Someplace between 24 and 26, certainly no later than 30. Okay, what are the last parts of the brain to develop? Frontal lobes. What's in the frontal lobes? Insight, judgment, being able to set aside the immediate gratification for something else that happens later. Okay? I mean, how many in this room have had adolescence? I mean, not only in your personal life, but I mean, accepting responsibility for them. Does any of this ring a bell? Okay, I mean, adolescents are notoriously difficult to deal with. What's going on? No frontal lobes yet. Okay, they're not going to, I mean, and it's hard to say to a 14-year-old, come back and I'll answer that question at 24. I mean, because they're not going to take that, okay? And inherent in that becomes also risk-taking as part of that behavior, okay? And part of the risk-taking then is the usage of substances, which are now ubiquitous, and we have a community awash in heroin and a variety of other drugs that are sort of poisoning the frontal lobes of the brain. Now, if you picture the addiction pathways within the brain, they actually take place at a very primitive level. And it's in the limbic system of the brain. And that's the part of the brain, nobody ever wants to think about this, but this is the part of the brain that we have in common with like alligators and crocodiles and reptiles and stuff. And I mean, it's like crocodiles and alligators are not known for their capabilities in higher thought and weighing risk and benefit, right? Okay, but that's what we have also at some level with regard to drive. What happens? The frontal lobes then exercise restraint over that limbic system in the normal individual. But what happens when you introduce drugs into the system, the drugs corrupt the frontal lobes of the brain. The same way that your computer gets hijacked by a computer virus. That's exactly what's going on. Okay? And so if you think of addiction as being a little pathway in the woods, and you may be born with tremendous resilience so that you do not become addicted, or you may be born with tremendous vulnerability. I mean, you can go around blaming your parents and your grandparents as much as you want. I don't think it's very functional, okay? But you, I mean, you're born with what it is that you have. I mean, some people in this room probably were tall enough to play basketball. Other people here, they're vertically challenged, or not. Okay, it's just the slurry of what you're born with. But this vulnerability to addiction is something that you're born with. And as these pathways then become exercised by drug usage, that starts out as something that's sort of fun. What happens is the little pathway in the road gets a little wider. And then what used to be a little bit of a pathway turns into a 2-lane road. And then after a while it gets paved. And after a while it becomes 17 lanes doing 145 miles an hour in both directions. Okay? Which is my patient population. Now if you just say, stop taking drugs, what did you just do? And let's just say they do. Incarceration or something happens. What did you do? You just put up a road closed sign. That's it. The infrastructure remains, probably for life. Okay? So this whole just say no stuff works if you're not addicted or not prone to addiction. And so I think going forward, one of the things to think about is prevention programs for kids at risk so that you keep them away from as little cumulative load of this stuff as possible with positive competing behaviors. I think that that's what you would like to do as a community. And I started thinking about this a little bit more. I think probably nationally what's needed is something that has the same political will behind it and the same amount of money nationally as a space program, right? I mean, those of you that are old enough to remember that. I mean, that was a big project. But I think that if you really want to attack drug usage, I think it's probably going to have to be on that scale. And that's a little bit grandiose. Okay, I understand it. But everybody can do something. But I think it's very, very important to have that recognition. Now, as it turns out, they actually have rat models of this type of stuff, of addiction. Does anybody know what a Fisher 442 is? A Fisher 442 is a standard everyday laboratory rat. And it's a nice little rat. They don't bite too much. They don't get rat diseases too much. They don't get like cancer or heart disease or anything. And they're sort of friendly. And they're the classic laboratory animal. Okay? Now, in general, they don't get addicted. You can get them addicted if you put a cannula in their tail vein, okay? And you shoot them full of heroin or whatever. And you can get them to press the lever. So that in other words, what has happened is that the want had become a need. Now, if you take the Fisher 442 out of that cage and you put it with a bunch of other little rats, then it won't take drugs, okay? I mean, they probably sit around, have a little AA meeting, NA meeting, whatever, 12-step meeting, you know, spiritual talk, whatever. They don't take drugs, they don't. But you can make them take drugs again if 1 out of 3 conditions are met. One is that you put the animal in the cage where the addiction took place. So what is that? People, places, and things, right? Okay, if you expose them to a noxious stimuli, like a foot shock, well, what's that? That's pain. Well, what could that be? That could also be the emotional pain of a divorce or something, death of a family member, loss of a job, all of these types of things. Okay? Another one is if you give them an unannounced priming dose of a drug. So you cannulate the tail vein again, and you squirt some dope in the tail vein, unannounced. You'll get them to relapse. So what is that? My. Now you just have a model for what happens when an addict or somebody that's prone to addiction goes to the dentist and gets a script for 20 Vicodin. Okay. Now for a few dollars more, you get yourself a Nancy Reagan rat. Okay? And these are very abstemious creatures. They just say no. They do. They do. And what they do, the damnedest thing, what they do is that, well, it's 9:40. I don't think I'd like any heroin. It might disturb my rat appetite, and they'll be bringing Purina rat chow at noon. I'll just say no. And there is nothing you can do to get them addicted. You can't get them addicted no matter what. Okay? So now you have a model for people that are resilient. Okay? Now for a few dollars more, you can get yourself a Lewis rat. And a Lewis rat, this is a scary animal. I thought about getting one as a pet, but I thought it'd be a bad influence. What these will do is they will instinctively push on the bar to take drugs and alcohol to the exclusion of food and water until they are dead, having never been exposed to it before in their life. My. That's a scary one, isn't it? But as you're in your clinical practice or you grapple with these types of things, I mean, I don't want you to start thinking of patients in these terms, but I do want you to understand the behaviors. Okay. Now, another thing about early diagnosis is I did emergency medicine for a long, long time, and I swear to God, I don't think I diagnosed addiction very much or alcoholism very much, because I was using the Cage questionnaire, which, if you think about it, is not too sensitive. Anybody know what the Cage questionnaire is? Yeah. Okay. Have you ever had, well, actually, I wasn't even using the Cage questionnaire. I was using the Dave Withers version of the Cage questionnaire. You don't ever want to use the Dave Withers version of the Cage questionnaire, because I didn't want to necessarily look for addiction. But the first one is, have you ever had to cut down on your drinking? The second one, or drugging, have you ever felt annoyed by someone talking to you about your drinking or drugging? Okay. The third one is, have you ever felt guilty about drinking or drugging? The fourth one is, have you ever had to take an eye opener in the morning to quell the shakes or get rid of the withdrawal? I did emergency medicine, and here's the test that I was using is, if you open a fresh fifth of bourbon, do you throw away the cap? Second one screens for drug usage, and that is, have you ever had a urine drug toxicology test pre-employment come back positive for pesticides as a drug of abuse? The third one screens for unmanageability, which is, have you ever gotten into a fist fight with a priest at a wedding reception? The fourth one screens for grandiosity, which is, would you quibble with the following statement? Incoming artillery fire has the right of way. And I recently found a fifth one that I've added, which is, have you ever had a sunburn of the roof of your mouth? Now, here's my point. If you start using these types of screening criteria that are not very sensitive, you're going to miss a lot of addiction. It's like pencil-thin stools screening for rectal cancer. It's like a fungating chest mass screening for breast cancer. Okay, they're not sensitive. And so what has to happen is you have to look at this stuff early before the pathways get so developed. I think that would be incredibly, incredibly important. Now I use much more sensitive screening tools, by the way. But I have, how am I doing on time?
You're good. You got another half hour. You're good.
Really?
Yeah.
All right. Well, okay, what I did is I brought a model. I'm a dinosaur. I do have some PowerPoint slides. We might even get to them. But I can never depend on this stuff working. So I use fruits and vegetables instead. Because fruits and vegetables rarely let you down. Now, just to illustrate what we're talking about, what we have here is the cerebral hemispheres with the frontal lobes of the brain. Nice little squash here. Okay. And we have the nucleus accumbens right here, which is the orange. The nucleus accumbens is the pleasure center of the brain. And the pleasure center of the brain is the thing that goes, I like that. I need to have more of that. Then we have the amygdala, okay? And what that is responsible for emotional memory, which we alluded to a little bit before. And then we have the hippocampus, which is people, places, and things. Now, can you still hear me? Okay. I have this friend by the name of Mario, and Mario is extremely bright, classically educated as a pathologist and an internist. The only problem was he smoked Gaulois cigarettes. Anybody know what Gaulois are? It's like they're 9/10 nicotine or something, like one puff and you vibrate for 3 days. So he moved to the United States and he switched to a low tar and nicotine substitute called Marlboro. And he smoked 6 packs a day of Marlboros as a low tar and nicotine substitute. Okay. And we finally got him titrated down to 2 packs of Carlton or Merit or some sort of cabbage. But he just thought he was going to die. I thought he was going to die. Everybody knew him thought he was going to die. And one day, we were sitting in a restaurant, and you can tell he's not alcoholic, because what he did is he ordered a beer, had 2 sips out of the beer, pushed it aside, and drank the coffee. That's not addiction. There is no alcoholic that would do that. They would be worried. I worry about that beer to this day. It says something about me. Anyhow, what happened was he said, how do I quit smoking? And so I put him on the patch, I put him on the gum, I put him on Wellbutrin, and damn if he didn't quit smoking, okay? And I gave him the text Alcoholics Anonymous to read, and 2 days later he called me up and said, Dave, I'm an alcoholic. And I said, Mario, that's very nice, but I don't know if you've noticed, but you don't drink. Alcoholism normally requires the presence of drinking. He said, I know, but I think that way. I said, yeah, that's why I gave you the book. He said, do I have to go to meetings? I said, no, but you do have to internalize it and relate it to smoking, because otherwise you're going to die, because that's what's going on. He said, okay. Now, a few weeks after that, he called me up and he said, I went deep sea fishing off the coast of North Carolina. I said, Mario, that's absolutely great. He said, Dave, on the second night, I smoked a cigar. I said, Mario, this is not going to go well. Now, great alcoholic refrain. Here's what he said next. I never smoked cigars, and I didn't inhale. That's alcoholism, all right? He just doesn't drink, all right? Actually, he's not prone to drinking, but it's addiction, okay? It's addiction. This is addiction. This is addicted thought. It's very, very important to be able to pick up on this stuff, okay? Because if you start looking for the Dave Withers screening test, you're going to blow it. You look for this stuff, you find it. Okay, now, I said, I don't care what you think. What you think is not important. Call me up in 2 weeks and tell me how it goes, because it's not going to go well. All right? So 2 weeks later, he called me up. Now, you got to understand, Mario hates the taste of fish. Can't stand fishing. You get him near water, he gets seasick and pukes. Calls me up. I said, Mario, how's it going? He said, Dave, you won't believe what's going on. Every night when I go to bed, for 8 hours, I dream about fishing. Okay. Now, if you can understand that story, you can understand addiction. What has just happened? The nicotine addiction in the frontal lobes of the brain want him to go out to the quick fill and buy 2 cartons of Marlboros. It knows that he won't buy the 2 cartons of Marlboros, so it does the next best thing. After 10 days, the addiction has had enough of this abstinence stuff and starts telling him he belongs on a fishing trip. And all he knows is that in the morning, he needs to go find a travel agent. Now, he's interesting because he remembers his dreams. I don't remember my dreams. But think about this. Think about a disease that is so subtle that it co-opts. It takes over the frontal lobes of the brain. Okay, so this is what's going on. Nucleus accumbens gets banged on by whatever drug it is. Heroin is the one that we're talking about mostly today, okay? And the nucleus accumbens, by the way, doesn't get banged on directly by heroin. It gets banged on sort of obliquely, and the rest of the brain, if you will, are sort of the sensory organs for the nucleus accumbens. Okay? And then all of the thinking in the frontal lobes of the brain gets readjusted to somehow have that thought make sense. Now, let's get back to like neuronal transmission. Okay? Because we're talking about a neurologic disease. And the basic unit of neuronal transmission is the synapse between neurons. afferent, efferent neuron, what happens is one of these neurons blows out some schmutz, which is called a neurotransmitter, into the synapse. Over here, there are receptors, specific for the substance. Now, anything that changes the release of these neurotransmitters modifies the reuptake of this, which is sort of the tidy bowl function, getting this stuff out of the way, or either bangs directly over here or facilitates the banging on this neuron, will change the means of neuronal transmission. This is what's going on inside the brain. Okay? And the types of neurons, the relative densities of them, and the types of actual receptors are all coded for genetically. That's why some drugs have different effects on different people. That's also why these things are moderated. I mean, in the case of a GABA receptor, it has, which is an inhibitory neurotransmitter, has a lot to do with stuff like how bad somebody's withdrawal will be from benzodiazepine or alcohol. You have people that drink a pint of whiskey a day and have no withdrawal, or very little withdrawal. You have other people that drink half a pint a day and get DTs. Why is that? It's this type of variability. Okay, that's what's actually going on. And if you cone down here, as to look at these receptors, here's what's going on. That's what a receptor looks like. Okay, representation. What happens when it gets hit by something specific? It gets triggered. Okay. But what really happens is it gets a little more complicated than that. There are all these different types of subunits in here. My, now we have a benzodiazepine receptor. My, now we have a barbiturate receptor. My, now we have an alcohol receptor. And so these modify the means of neuronal transmission. And that is why different people will have different effects and also different vulnerabilities. That's how that happens. Now, girlfriend one time said, was telling me about this guy, but I'm going to call him George. George drank a lot, okay? And here's what happened. What happened was he did pretty good in high school, and then he took the SATs, and he got a 1600, which is not a bad score. Then he went to Notre Dame, which is not a bad school, and he got a 4.0. Then he went to law school, and he got a 4.0, and that's not a bad score either. Then he was making like $1 million a year. Not that that's a marker necessarily for anything, but he must have been fairly motivated, successful, whatever. The problem is he drank. Now here's what happened. What happened was he lived in one of these housing developments where everybody's house looked exactly the same, right? So what he did is he pulled into the driveway. Problem was it wasn't his driveway, right? Walked up the front steps, not his steps. Opened the door, not his door. Goes upstairs, not his stairs. Goes to the bedroom, not his bedroom. Lays down in bed, not his bed. Okay? There's a woman in bed. This is a true story. Woman in bed. Probably has alcoholism or drug addiction, but nobody knows. Okay. And either she is quite welcoming or is too blasted. Well, anyhow, I don't know how that part of the story went. But in the morning, he goes to the closet and puts on a suit. Not his suit. Goes down to the garage, starts the car, managed to get the garage door open. The only thing was he parked outside. Not his car. Goes to work. 20 minutes later, the wife and 3 children barge through the door saying, "Where were you last night?" His response was, "Home, in bed with you." She said, "Don't be ridiculous. Where'd you get that suit?" "It's my suit." Well, it's not what suit. So anyhow, they turned back and found the laundry markings in the suit, and they figured out who the suit belonged to. Returned the car, returned the suit. Okay, anybody want to know, anyone want to guess the next piece of the story? A few months go by. Pregnant. Yep. Okay, now here's what happens. 2 large alcoholic families, right? And so what happens is little George gets brought over to Uncle George on Sundays for visitation. Nobody in either family sees anything particularly wrong with this. Okay, this is how distorted things have gotten in the frontal lobes of the brain. Okay? Now here's what makes it true alcoholism, though. So they finally have a family intervention, and they say to him, this is a mess. What do you have to say for yourself? Exactly. And his response, now this is what makes it drug addiction and alcoholism. His response was, I always wanted a boy. Okay, now if you can understand that, you can understand the changes in the executive function in the frontal lobes of the brain. You can't excuse this. There's no way on God's green earth that you could possibly make up any sort of thing that makes any sort of sense whatsoever. The ability to excuse the inexcusable in 1/100 of a second and move on. Okay? And if you see a lot of drug addiction or alcoholism, you will see these types of things. Makes no sense whatsoever. Totally crazy. Okay, what has happened? Frontal lobes of the brain have been corrupted. That's what's going on. Now, a few years ago, I gave a talk on addiction at WCA Hospital, and my surgical colleagues then were cloistered around a phone because they had finally found a case of addiction. Now, here's what happened. There was some poor guy that was up on a pitched roof, 3 stories up, drinking a 30-pack of beer with the dog. Okay? And he got halfway through the 30-pack of beer, and it was 4 o'clock in the morning, and then he fell off the roof. And then he fell 3 stories, broke both femurs that were sticking through his legs. Okay? Broke his pelvis, broke his spleen, kidneys, ruptured his bladder, that type of stuff. And what happened was the neighbors came out to hear the dog on the roof yowling, which awakened the neighbor. I mean, and they were trying to figure out what a dog is doing on a roof like a steeple, okay? They finally got the dog down, they looked, and it's like they got this bloody thing in the middle of the street. They got him to the hospital, and after they took him off the ventilator, I went in to see him because they had identified a case of possible addiction, right? Now here's what happened. I went in to see him, and I said, do you have trouble with drugs or alcohol? And his response was, no, I have 2 broken legs. See, what has happened? What has happened is the frontal lobes of the brain have become so corrupted over time that that is not the truth, but it becomes his truth, and he believes it. Delusion. What's the real answer? The real answer is I've become so habituated to substances that my judgment is so impaired that I put myself and others at risk. I narrowly escaped dying, and I need to change. Will you please help me? That's the real answer. But he's blind and can't see because of the substances. This is the problem, and this is the frustration in trying to deal with people. Okay? People not uncommonly come to my office, and they have been remanded there to treatment or something in lieu of jail or whatever, incarceration. You know, and I'll say, why are you here? And the response sometimes is, judge said. Okay, why'd the judge send you? Got arrested for drinking and driving, drugging and driving. I said, well, why'd that happen? The cop didn't like me. And that becomes his truth. If you ask him at that point in time, that he's not lying. Okay, it's complete delusion, but he believes it. What's the real answer? The real answer is, I was putting myself and society at tremendous risk. I need to be locked up. That's what should happen. As a result of profound grace, I'm now in recovery, and I need to listen. Okay? And so this is the way things have to change. Now, how to treat all of this stuff is beyond the scope of this talk, I think. But this is what I wanted to do is give you a feeling and a nature of addictive disease. And there are not good drugs yet to treat addiction. Okay? Methadone works for opioids and heroin. You're going to have a methadone clinic, and it has to be well run. Okay? And it's a substitute. Ideally, you'd like to see abstinence, if at all possible, and then rearrange the frontal lobes of the brain. You would like to see, I would think, education in a way that you prevent as much of this stuff as possible. Like if you can keep the frontal lobes away from drugs or alcohol until age 30, how much do you decrease the incidence of addiction? Anyone want to guess? 90%. Okay, so if you think about it, it's a pediatric and adolescent disease. Prevention should be the goal. I mean, it's like I'm treating stage 4 cancer, if you think about it. If you got diagnosed with addiction today or HIV today, which one would have a better prognosis? HIV, without question. Think about it. Okay, this is how ugly these diseases are. These diseases are not troubles of moral failing. They have a biological underpinning. Understand the behaviors have to stop. Suboxone can be used, but it has to be done extremely well with tremendous accountability. Increasingly in my practice, I see it done poorly, and I take care of the mistakes. I happen to be in an abstinence-based program. Narcan, to prevent death in the case of near-fatal or fatal overdose, is a no-brainer. My thought is, I don't care what the law is necessarily, my thought would be, order 2 cases of it, 10 would be better, hand it out, and if somebody ever squeaks legally about what you're doing, call my friend Dale Robbins, because he'll probably defend you for free, and I just looked him into it. Because I don't think it's ever going to go to court, right? Because it's such a no-brainer. I mean, ideally, you would like to do all this stuff legally, but this is such a no-brainer, I don't see how this could possibly matter. I mean, it's like getting arrested for giving water to somebody in the middle of a desert who's dying of thirst. This is crazy. I mean, it's like, where is the liability in that? And the answer is there's not, or there should be none. Let me sort of, if I have a couple of minutes, I'll buzz through the slides. If I'm out of time, it's okay.
Yeah, we got about 15 more minutes, so help yourself.
Okay, well, let's wander through these and see what I got up here. I grabbed a talk. Can we have the first one? Addiction. Persistent use of a drug or behavior despite adverse consequences. It's usually associated with tolerance, withdrawal, depending on the drug, unsuccessful attempts to cut down or control usage, family or occupational responsibilities curtailed or given up, which is what Dale was talking about, going to unusual lengths to get the drug. We've all got stories about that. I got people that come in and the parents will call me up begging to please treat the kid for addiction. I said, what is the problem? She says he keeps going to the dentist to get his teeth pulled so he can get a script for Vicodin. These are I'm not making this, you can't make this stuff up. Okay? I mean, think of the tragedy in this. These are tragedies, okay? Using despite medical or psychiatric contraindications. 3 out of 7 will make a diagnosis of dependence. The criteria are changing with the new change in definitions, but that works pretty well. But next slide, the real one is doing something that's very bad for you compulsively and then lying about it to cover it up. Next slide. Repeated drug use leads to changes in the brain, which is what we're talking about. It's not a matter of willpower. It's not weak will. It's not a matter of self-control. And here's why. What happens is, if people have tremendous willpower, what it means is red light can't go through it. There's a red light. I can't go through it. But what happens? If you change the frontal lobes of the brain right here, what have you just done? What you have just done is you just flip the red light green. So here's what happens. Dave? Dave, you can't sleep. We got a medical problem here. Yeah, medical problem. Yeah, medical problem. Not only that, you might get a headache. I'll bet you 4 Ambien, a glass of wine, and 4 Percocet and a bag of heroin would help. Yeah, medical problem. Okay, what just happened? Red light flipped green. If you have a bucket of willpower and your red light flipped green, all that means is you're going to be off to the races. That's all that means. So saying to somebody that they should have willpower or whatever, that's going to work for about 80% of the population, maybe 90%. But the ones that are devastating this community and causing the death and heartache, okay? And it wouldn't be so bad if the addict just died. That'd be terrible. But the carnage that it takes on the family and friends that have the misfortune or fortune to love them. And for every addict, 7 other people are gravely affected. It's a big deal. Okay, next slide. Okay, we talked about this. If it's a serious problem, lifelong abstinence is the goal. Let's go on. Imaging studies now, this is a PET scan, and there are differences in the way that the brain lights up with regard to motivation, reward, and inhibitory control, which is what I was talking about with my squash here sitting on top of the orange. Let's go on. Experimentation begins in adolescence. Now, this is a little bit of a spooky slide. Sort of looks like a couple of kids having fun, but if you notice, the kid here on the right is huffing glue. Risk-taking is increased in adolescence, novelty-seeking is increased, and development of the frontal lobes is not complete until the early 20s. So it's executive control, decision-making, being able to weigh risk and reward. Those are all things that happen in the frontal lobes. And there's an impetuous and immortality appended to youth where, I mean, you can't convince a 17-year-old that they're going to die. It's very difficult to do. And part of that is they just don't have the capacity to see that. And normal development processes get interrupted. And if you look at them after they've been using substances for a long period of time, you can almost see that they get stuck at whatever year their development was at, sort of emotionally. Let's go on. Well, it sort of depends on what trips you trigger. You know, I mean, here this guy's doing a little skydiving, a little bit of a risky behavior, I would think. But it seems to be, what's going on? His neurotransmitters are banging on his nucleus accumbens, and he's getting a charge out of it. It's also risk-taking behavior, by the way. Okay, what's going on? The end analysis for this is a charge of dopamine being released, banging on the nucleus accumbens, and anything that interferes with neuronal transmission, okay, will change levels of dopamine within the nucleus accumbens. Let's go on. Increases in dopamine are 5 to 10 times greater with drugs of abuse. And in general, the drugs that have the rapid onset of action have a greater abuse potential. So that's why shooting heroin IV is a rapid up. It takes something like 20 to 30 seconds to get high on a shot of heroin. Okay, death can supervene in a couple of minutes too by respiratory failure. Ugly drug. Okay, next slide. Brain has plasticity, and drugs become, instead of just liked, they become a need. A want becomes a need. Has to have it. And then the rest of the thinking gets adjusted then to make that happen in these complex behaviors for drug-seeking behavior. Okay, there are physicians in the audience. How many of them have had prescription pads stolen by, how many have had drug-seeking behavior where someone comes in, there is no disease. The disease is addiction, but every symptom known to man will be there to attempt to find whatever drug it might be. Let's go on. And this is just where all this stuff is in the brain. Sort of, I like my fruit model better, but you got the real one. And, okay, relapse behavior. And people, before they actually pick up the drug, it's not like they happen to be sitting at a traffic light, okay, and they get struck by addiction. That's not what happens. What happens is, it's this slippery slope that actually you can watch them, and they get sort of irritable. They stop doing the recovery-oriented types of things that keeps them in recovery. Okay? They get socially withdrawn, not uncommonly. Okay? And then until finally something happens, and then they pick up the drink or the drug. In this case, we're talking about heroin, and they're off to the races again for some sort of opioid. Let's go on. Can't be cured. Can be brought into stable long-term remission. Naltrexone, buprenorphine, methadone have some role and may be useful. But in the end analysis, it will become a hole in the soul through which blows the cold north wind of life. If there's only one phrase that you could remember from this talk, that would be a good way to remember it. It's a primary disease of the brain. And here's where psychiatrists generally blow it, by the way. Okay? I'm not a psychiatrist. I teach psychiatrists, but I'm not a psychiatrist. Here's where psychiatrists blow it. Psychiatrists, historically, have thought that if you took care of the depression, then they wouldn't be addicted or alcoholic. No. What it is you can have heart disease and addiction. You can have mental health disorders and addiction. You can have HIV and addiction. You can have TB and addiction. Addiction is a primary disease. Now, I'm not saying that there are, for instance, anxiety disorders. I want to say something like 80% of people that have trouble with anxiety, severe anxiety, will gravitate toward benzodiazepines or alcohol, and well over half of them will get addicted. Okay, so there is that type of link, but you got to be careful, laying somebody on the couch doing psychoanalysis and thinking they're getting cured. Okay, and here's the other thing that an addict or an alcoholic will be afraid of. They're afraid of being judged. Okay, they're very, very sensitive people. It's almost like they have no skin. There might be a blustery exterior. That's to disguise something else. Okay? Primary disease of the brain. Let's go on. Coercive pressure is effective. Drug court works. Carrot and stick. You can have employer mandates. You have EAPs and all that type of stuff. Family pressure with clear consequences that are not empty threats. And it's interesting. You have to understand, most interventions fail. And if you're going to do an intervention, I get involved in this type of stuff in physicians, sometimes attorneys, sometimes airline pilots and stuff like that. But what you have to do is line up all your ducks in a row and get everybody on the same page. Okay? And there's usually one person in the bunch that will crumple at the last minute and become enabling. And it will fail. And the alcoholic or the addict will go after that person like radar, manipulate them to their advantage. Okay? And it will fall apart. Nobody will know why. So if you're going to do an intervention, first of all, know what it is that you're doing. Second of all, be prepared for it to fail. Third, make sure that what it is that you're spelling out as a consequence actually takes place, as opposed to it being an empty threat. It was Lyndon Johnson that said that threats are cheap and ultimatums are expensive. Not to delve into politics, but it's appropriate. Let's go on. This talk was given, we could stop now. Part of this talk was given at a medical school for medical students trying to prevent addiction before their possibility to use the power of prescription ran amok. But the other thing is that the heroin addicts will be so wily and frequently so able. There have been studies of formal IQ tests between heroin addicts and PhD candidates. Guess which ones scored higher? Heroin addicts. So you're going to have to know what it is that you're dealing with. So if you could hang your hat on one thing, it's genetic. At least half of it is genetic. Other half is environmental. Big variability in the presentation of this stuff. The behaviors that you see are the symptoms, and when you treat addiction, lives will be saved. Naltrexone is a no-brainer, and it's going to have to be a very comprehensive approach. Otherwise, you're going to see a further decay. And I see this stuff in the places that I go. And I thank you.